Well, hello, everybody. This is Dr. Bill Curry. I'm a general internist at UAB, past president of the Medical Association, and I'm currently governor of the state chapter of the American College of Physicians for Alabama. So I'm really excited to have our chair of family medicine, Dr. Irfan Asif, join us for a conversation about what it's like being a primary care doctor in this upside down world of COVID-19. Irf, welcome. Thanks for joining.
Yeah, thank you for having me, Bill.
So, even before all of this, we realized that most medicine is practiced in the ambulatory setting, 95+% or whatever of medicine. And it's still true of the COVID-19 epidemic that people are being cared for at home or in their nursing homes or wherever they may be, much more than they are in the hospital, even when they are positive with this disease. And yet a lot of the focus, perhaps most of the focus, particularly about treatment, is on the inpatient side. So what is the difference in the way this is impacting ambulatory practices, especially primary care, non-subspecialist practices, compared to what we hear from our specialist friends?
Yeah, it's a great question. So I know with our particular journey, we work within a big healthcare system, and when this pandemic started, I actually was searching for who the partners were going to be on the primary care side with which to care for patients. With a big sort of tertiary quaternary center, most folks were focused on what do you do on the inpatient side, as you suggested, but we were able to find folks who were really thinking on the outpatient side. So thinking about yourself, thinking about Stuart Cohen with Prime Care, and even reaching out to other community partners, at least here in Jefferson County, such as the Christ Health Center and CAHABA, the CAHABA Medical Care Group. I think we've all come together to figure out what does this mean for primary care. On the micro level with our clinic, we had to make a rapid transition to telemedicine. Over the course of the first 2 weeks, we rapidly implemented a telemedicine program that consisted of phone calls and video visits. And we saw the number of in-person visits drop to where right now, probably a little over 4 weeks after the pandemic, we have about 10% of patients that are coming in person, about 50% that are doing video, and about 40% that are doing phone calls. I'm sure people would have a lot of questions related to that, but just wanted to share our experience. Most of the older patients, those that are underserved, were less likely to be able to do the video as opposed to the phone. But otherwise, it's been going okay. Other things that we learned with sort of the telemedicine piece was, as this evolved, there were some insurances that may not have been covering it initially, but most insurances now are covering the video visits and the telephone visits. You can actually do quite a bit in terms of physical exam, especially over the video. Making sure your patients are alert and oriented, whether they're in distress, whether they have a normal affect, normal respirations, non-labored breathing. You can check for any rashes. I actually do an orthopedic exam where I stand up and show patients what they should be doing, and have them repeat the maneuvers with me. So you can still capture a decent physical exam and provide counseling to patients. So that was step one for us.
Let me ask you a little about that. Yeah, so obviously this is early and there's a lot going through everybody's minds on a given day, but is it fair to say that it's possible that might change the way primary care gets practiced from here on, with that sort of penetration with virtual visits?
Yeah, I mean, anecdotally from our side, we've actually have had good patient experience with this. All the patients have been really appreciative of the fact that we're able to manage their medical problems. And I can't tell whether the appreciation is simply because we're able to still care for them during a pandemic setting, or whether this is something that they actually want to do moving forward. And we actually have put together a team that includes Ken Sag and others to try to study this, to understand what the patient experience might be like. I think that information is going to be really powerful. To your point, I think that this is going to change the way that medicine is practiced. That's not to say that there won't be any more in-person visits, but I do think that virtual care is going to be a large part of what we do in the future.
Sure. So to COVID specifically, when you get a COVID positive patient and you're following them as a primary care physician now, what's your approach to that? How are you doing it?
So it's a good question. So to kind of round up the first piece of this, we have the virtual visits. We also have a curbside clinic that we set up for non-respiratory diseases if we need to see someone. And then we can talk about this a little further, but we created a COVID-19 specific clinic for COVID patients, and those would be in-person visits.
So I guess everybody has a little bit of an idea of what a virtual visit would be, either on the phone or like we're doing here with Zoom, or whatever variation of that. But tell us about the curbside visit. What does that look like?
Yeah, so our goal is to try to minimize the exposure that patients would have to anything like COVID. So we don't want them necessarily coming to the hospital if they don't need to. So we actually have a tent set up outside of our clinic. It's almost like a drive-through service where the patients would come through. They could get out, and we could do different things if we needed to. Again, do well child visits if we had orthopedic things that we needed to do where we couldn't capture those things via a video or a telephone visit. Those are things that we'd be able to do in this curbside clinic. We started small, so we opened this about a week and a half ago, and we probably have 4 patients in a half day that might come to this curbside clinic.
So some people get out of the car and some don't. Just depends
Correct.
on what's going on there.
Exactly.
And then you have the specialty, not specialty, but you have a designated COVID positive respiratory clinic that you've started to.
Correct. So you asked the question about how do we manage COVID patients, and so we can get into some of the treatment stuff here in a little bit, but the general idea is that all the COVID patients would have a virtual visit either through the telephone or video, and then we have a triage system where we look at symptoms. We've actually created a scoring system to try to help guide physicians on whether those patients, if they're laboring in their respirations, if they're hypoxic, if they're short of breath. So if they need more information that we can get on the video visit, then they have the opportunity to come to this COVID-19 clinic. The clinic has 4 exam rooms. It has the opportunity to get vital signs, chest x-ray, labs, EKG for those patients to triage whether or not they'd be safely managed at home or whether they would need to go to the ED or a direct admission. That clinic started just at the end of last week. We saw a handful of patients, and all of those patients were able to be managed at home once we got that information.
That's great. So let's mention just a little about treatment before we start getting short on time. So we know there are big clinical trials in place for some of the antiviral drugs. There are clinical trials on at least beginning to crank up with hydroxychloroquine and azithromycin, but most of those are focused on the inpatient side. At least the protocols from MGH, our own protocol at UAB, list those for moderately severely ill patients who are in the hospital already. So what are the options for ambulatory treatment of COVID?
Yeah, that's a good question. So, the UAB algorithm currently breaks out what you might want to do prophylactically, what you may do for asymptomatic patients, what you would do for outpatients, inpatients, or those in the ICU. And for those that are outpatient, asymptomatic, or prophylactic, really anything that we would do would be largely supportive. We currently don't have anything that would say to provide some of the medications that you described, such as hydroxychloroquine or azithromycin in the either, for example, the prophylactic, asymptomatic, or even in the outpatient setting. That being said, there have been some studies and other groups that have tried to investigate whether or not to use some of those medications for either those with mild disease or maybe those with high-risk disease in the outpatient setting. And while I can't tell you what you may or may not want to do with practice after reading the evidence, I would probably recommend that maybe we all either come together or find a way to capture that data in some registry so that we can take a look at what the evidence might be down the road. Because I think that's all, this COVID pandemic is so new that there's an absence of information, and the more that we can capture that, the better off that we're going to be in the long run. There are some herbs, supplements, vitamins that people have been investigating. Those might include vitamin C, vitamin D, zinc, and hesperidin or quercetin. The jury is still out on those, but much of what they have are antioxidants, and I think those could be one thing that we may be able to offer in the outpatient setting, aside from some of the medications that we talked about.
Well, thanks. As we sort of head toward closing here, I want to mention physician wellness in this. Obviously, our job is to keep our patients well and to help them get well when they're sick. But at the same time, we have to maintain our own capacity to do that. And even before this epidemic, this pandemic, over 50% of primary care physicians in the U.S. scored high on burnout. There are variety, of course, a whole long litany, a variety of reasons, and why that happens. But what's your approach, and what do you with your family medicine colleagues recommend about maintaining wellness of the physician in this situation?
Yeah, it's a good question. I think there are two factors here that could add to burnout. The first is sort of taking healthcare and flipping it on its head. Going from in-person to telemedicine, for example, is a big lift. And I think that in and of itself could contribute to burnout. The second is sort of the social isolation. We talk a lot about social distancing, and that's not just for patients. That's something that we as practitioners probably feel, and the social isolation could also contribute to burnout. My recommendations for people would be to try to find ways to take care of themselves, both from a mental and a physical standpoint. For me, that's exercising, also eating healthy, and if people find that they're not able to exercise the way they did before, for example, there are programs like the YMCA 360 or others that you can do online. You can share those with patients, but those are also things that we could do as providers. The last thing is, while we may have the social distancing as something where we can't meet in person, I think doing things like this, the Zoom calls, you're seeing that more in the lay public setting where people are doing Friday night happy hours or things where you can still connect with folks. I think we should remind ourselves that the technology can somehow be helpful for us, so we're not completely socially isolated.
Well, thanks. We're sort of at the end of our time, but is there anything else you feel would be helpful just to mention as we close to primary care physicians particularly?
No, I'd say the lasting message that I would love for people to take away is that we're all in this together. I would love for us to find ways to communicate, to collaborate, to share best practices and experiences, for us to lead the way maybe in developing evidence-based protocols. I think this is a new opportunity for us, and I know that I'd certainly be really excited to work with others who would want to work together. And Bill, I want to thank you for giving me the chance to speak with you today.
Well, thank you for being with us. And I want to thank the State Medical Association for giving the impetus to start these videos. I do want to mention there are a lot of resources on their website, on the ACP website, the AAFP, the AMA. There's no shortage of information out there, whether it's about practice finances through Small Business Administration and the Payroll Protection Act and the CARES Act, and also about physician wellness, and of course about the symptoms and management of patients with COVID. Thank you, Irf, for being with us, and thanks for the work you're doing.
Thanks, Bill.